The question was to sort of comment on the fine line between pain management and over pain management or subtle euthanasia. So that's really a difficult question because it really depends on, the line depends very much on what the need is and whether the need for the medication is there or not. There are cases in which, in order to control the pain, patients essentially are have a very low level of consciousness because the pain is so bad that they can't deal with it. And so the intent then is to control the pain with, the consent of the patient and the family. To control the pain, even though it may reduce their ability to talk and to deal with issues. It rarely happens, it's not a common thing. Most times when palliative care physicians are involved, there isn't really a sense of a line there. I mean, what we're really trying to do is essentially have the patient be able to function and have pain control. And many times you're able to do that. So there's no real question about euthanasia. The real question comes, and it's called what we call terminal sedation. Terminal sedation is really a way of dealing with a person's significant, uncontrollable pain with medications that are going to make them so sedated that they won't be awake. The intent is not to euthanize the patient. The intent is to relieve the suffering, which is unrelievable in any other way. So I would say that I can't talk for all physicians, right? Because I know that there probably is instances where medication is given to essentially allow the patient to die without really, calling it that. I don't think it happens very often. It hasn't happened in my knowledge in my hospital, but there are always anecdotes about things like that. But I think in essence, in the palliative care world, that doesn't usually happen. The most common thing would be for patients to be given enough pain medication to control their pain so that they're able to function, is still to some extent. But in those instances where that's impossible and the patient is just in excruciating pain, that with consent of the family or with asking of the family and the patient, that we sedate the patient enough that their pain is controlled, but they're essentially not conscious. And from the outside, that sometimes looks like, subtle euthanasia. But it really, there's no intent and there's no evidence that that actually shortens a person's life. Okay? That what we're doing is really just controlling their pain and letting them sleep. If they're having that much pain, they're not eating and drinking anyway, right? I mean, it's just, that's the way it is. And so it's usually a short period of time between the time you start that treatment and the time they die, but that probably would have been the same had you not treated them.
So this is a question about advocacy and the fine line between how can you be helpful and not dominating. Good guidelines for advocacy, some things to watch out for. Maybe Susan and Jane would like to respond.
The one thing that I think of is simply to be really clear, or as clear as you can, that you know what the person wants, which I guess if you're coming in from someplace else, you may not really know. But I think I wouldn't want to ask something or, for a certain type of care or for doctors to do something if I wasn't pretty confident that that was what the person wanted. So I guess it just, in order to be a good advocate, you need to know what the person would want you to advocate for.
I can't really add anything to all the good things that have already been said, except maybe a word about that relative from hell. In my own experience, and it often is the person coming from afar, you know, who's been quite distant, and the other siblings are absolutely exhausted because they've been doing the lion's share of the care for a good long time. But people behave badly because of their wounds. And that person coming in being very demanding and domineering and kind of coming in on the white steed is probably feeling a lot of fear and guilt and helplessness. So it may be difficult as an entire family unit to address that, but if even one family member or a friend of the family or a visiting chaplain had a sensitivity, you know, if the patterns of communication within the family were observable, a sensitive person might sense that charged environment and then understand that there are some deeper needs that need tending to in the person who is going for control.
So the question and comment came from experience with L'Arche and family members who have often been distant from the person who is now facing the end of life. And should there be a better means of coordinating communication earlier on in the process so that it isn't at the end in a bit of a disaster? Would that be okay? Jane, would you like to?
I think that's really a question of sort of all our relationships in some ways is how do we keep them kind of going and good, you know? But I think just at least regularly contacting the family as much as you can, and especially if there's sort of significant changes that you're seeing, you know, to sort of start, as I say, as soon as, like you said, Lynn, as soon as you can, you know, to sort of get in contact. And I guess it's also probably some of that fear or the distance has come because the person is afraid to and doesn't know how to know, doesn't necessarily really even know the person with the disability very well if they've been distant. So how can we have how can we help them to get to know the person so that then they're also trying to do the best thing for the person? And that can be very, very challenging, obviously, but yeah, don't have any magic solutions there, sorry. Yeah.
I just have a couple of things to offer there. I think, first of all, sometimes, you know, these people that come from far away or wherever, they don't even have to be from far away, are just estranged family members oftentimes, and there's a lot of tension within the family just right from the beginning. It's been there all their life, and this is just like a focal point for it. And there's sometimes little we can do in terms of repairing the relationships that are causing a lot of the grief. But I think in some instances, you know, if it's a sudden illness that the person has had and gotten into trouble very quickly, there's sometimes no chance of dealing with the issues all that well. But if it's a slower process, then I think if the client is verbal and they have a say in what type of care they should have or want or will have, and if we do have an opportunity of getting some sort of directive from that person as to what they want, at least that allows for more clarity and at that sort of those, you know, few days that someone else has come in, and at least we can then say, you know, his wishes or her wishes are that this happen. And if you have that directive written reasonably clearly, then I think that really obviates, you know, gets rid of a lot of those problems that can occur just because this person thinks they know, know the situation better than everybody else. So, but sometimes I don't know. It's a very difficult situation in many times, and I think Susan's right. I think a lot of it is fear and guilt, and just wanting to be a part of the solution, and thinking that other people maybe haven't got it right, and unfortunately, it ends up being a conflict. And besides getting the counselor involved and all that sort of stuff, I think there's, sometimes not that much we can do. How do we deal with people who are in denial and aren't interested in advocating for themselves for care? I think what you're doing is the right thing. Is being with them, sort of trying to help them advocate for themselves, or offering to advocate for them, is probably the best thing. And these people that tend to be more reclusive and they live in an interior life, right? And they don't want any intrusion in that. And sometimes, making them do things that just increase their anxiety is not necessarily the best thing. Sometimes we have to wait for them to actually get seriously ill before we can, advocate for them properly. But I think the main thing is showing that you care, that there's someone there that is willing to look at the options for them, offer them the options that are available to them, and essentially sort of journey with them. And if it turns out that they get so sick that they require help, then at that point, oftentimes, they're more willing to look for help or allow people in which case you'll be able to do that. Unfortunately, as a family doctor, we believe very strongly in preventative health, but there are some people, it doesn't matter how much you see them, they still don't do the preventative things. So it's not surprising that there are some people out there that just don't want to do anything for themselves anyway. But I think because it's a personality, it's a way of being, it's how they've been formed in their life, and to try to put them in a situation which they're totally lost in is probably not the right thing to do, but to try and just sort of encourage them to take little steps at a time, and maybe eventually they'll go for that help. I'd offer to come visit them, but they'd know I was a physician, I think, so I don't think that would help all that much. Honestly, I think it's little steps at a time. I don't know if anyone else has
That's great.
an offer for help.
So I think the question is, when the decision maker is in fact the person who's perhaps least close and least able to discern perhaps the best needs and wishes of the patient.
I think that it's a difficult situation, for sure, and especially if the person isn't able to choose who they want to make their decisions when they're not able to. But there is, I think if you felt really strongly that it wasn't what the person would want, there is a Board of Consent and Capacity. And we've used them. Obviously it isn't something they usually do, but trying to get them to take on the care of the person. Or somebody could ask to have that responsibility. And then the Board of Consent and Capacity would decide whether or not that makes sense. They would want to know if there was family involved, obviously, and stuff. But there is a process there that could happen if you really felt that you needed to do that. But legally, there isn't really much you can do, I don't think. Yeah.
There's more of a case when the person you're talking about is verbal and able to make some decisions for themselves, obviously. the problem again comes in when, you know, it's a little nebulous as to what he or she would do in normal circumstances and what you think they would do. It's hard enough in someone who's competent to sometimes get them to tell you what they really want. It's even harder when you have a person who isn't capable of giving you a direct answer. And in those situations, I think you have to advocate in a way, gently initially, I think, to try to convince the person who's looking after, who's got the, you know, who's essentially the consenting person, to help them understand what that person, why you believe that person wants what you think he wants. And essentially, generally speaking, the people that are working with them are more able to make that decision. But unfortunately, we do have, you know, a legal system which gives people the rights to make those sorts of decisions about personal health. And I guess if you have a conflict, you can go to a board that will do something about it. But I think, you know, we speak as if that this is an uncommon thing. It's not necessarily that uncommon. That people come in and make decisions at end of life, which don't necessarily seem to be the best decisions for that person. And I think a lot of it comes down to communication. You know, how do we communicate with these people? How do we allay their fears? How do we sort of, you know, get rid of some of those guilt feelings that are making them make decisions which aren't necessarily the right decisions for them. It's a very, you know, as Jane mentioned, it's a difficult situation because everyone feels that they should have some involvement at that time, right? And that's why I think these advanced directives, again, I seem to be harping on it, but I think advanced directives are very important if you can get them from these people, right? As you say, some of these clients are not going to be verbal enough to be able to give you that information ever. So then you're stuck with just your sense, you knowing that person, and this other person who's a family member and has the legal documents telling you that they're the advocate for them, that coming in and making decisions which you think are wrong. But as I said, you have to sort of now you're advocating more with that person than you are with the medical system, right?